Thank you. Assalamu alaikum. Good afternoon. I hope you are not feeling too exhausted or too laziness after having the delicious lunch. I am Dr. Md Arif Hossain, working in the Department of Radiation Oncology, National Institute of Cancer Research and Hospital. I welcome you all to my presentation. And the title of my research was Comparison of Clinical Response and Acute Toxicity between three-dimensional conformal radiotherapy and intensity modulated radiotherapy as neoadjuvant concurrent chemoradiation for locally advanced rectal cancer. We are hearing the sentence for the last 2 days that cancer is a leading cause of death worldwide, accounting for nearly 10 million deaths each year. And according to the Globocon 2022, more than 1,67,000 people developed cancer and more than 1,11,000 died of this disease in our country. And this table collected from the Globocon 2022 shows that colorectal cancer is the third most diagnosed cancer and second leading cause of cancer deaths globally, with rectal cancer comprising 40% of those cases. And in Bangladesh, it is the seventh most common cancer. You know that the standard treatment for locally advanced rectal cancer includes neoadjuvant chemoradiotherapy, shown to reduce recurrence rate and improve outcome. Recent advancement of radiotherapy techniques such as three-dimensional conformal radiotherapy and intensity modulated radiotherapy offer more precise targeting with reduced toxicity. And these studies aim to compare IMRT and 3D-CRT in terms of clinical response and toxicity. The main objective of this study was to compare the clinical response and acute toxicity between 3D-CRT and IMRT as neoadjuvant concurrent chemoradiation for locally advanced rectal cancer. And the specific objectives were to assess the treatment response in terms of reduction of tumor size and to assess acute toxicity, that is grade 2 or more. It was a quasi-experimental study conducted from November 2021 to October 2022, and 3 tertiary care cancer centers, 1 University Hospital of Bangladesh, Bangabandhu Sheikh Mujib Medical University, and Delta Hospital Limited, and Hasina Mission Cancer and General Hospital were the place of study. 60 patients were included for this study, those who were divided into 2 treatment arms by purposive sampling. Arm A received preoperative radiotherapy by 3D-CRT technique and arm B by IMRT technique. And the patients were included in the study following some inclusion criteria, and they were locally advanced adenocarcinoma of rectum, clinical TNM stage were stage 2 and stage 3, that is T3, T4 disease and or node positive disease. And previously received neoadjuvant chemotherapy by FOLFOX4 8 cycle 2 weekly. And there were some exclusion criteria also. They were age less than 18 and more than 73 years, poor performance status, history of prior pelvic irradiation, prior malignancy or double primary pregnancy or lactation, and history of surgery, exit biopsy, or some serious illness or comorbidities. Before starting treatment, all patients were evaluated by history and physical examination, laboratory and diagnostic procedures, and some relevant radiological studies such as contrast-enhanced MRI of pelvis, contrast-enhanced CT scan of whole abdomen. We routinely done plain radiograph of chest, but whenever needed, we have done contrast-enhanced CT scan of chest. All patients were treated by external beam radiotherapy for arm A by 4-field technique and for arm B patients by 7 to 9-field techniques. Patients of both arms received external beam radiotherapy 50.4 gray in 28 fractions, 5 days in a week over 38 days in 2 phases. In phase 1, they got 45 gray in 25 daily fractions of 1.8 gray in 5 weeks, and in phase 2, they got additional 5.4 gray over 3 days as boost. And all patients have received concurrent chemotherapy with oral capecitabine. This image shows the 3D-CRT treatment planning, that is the plan 45 with various beam arrangements after contouring of the different volumes. And this is the plan, boost plan of 3D-CRT. And this is the plan 45 of IMRT, and this is the boost plan of IMRT. During treatment, patients were assessed weekly for symptomatic response and toxicity. And after treatment, end-line evaluations were done as the baseline investigations, especially the same imaging was done 4 weeks after completion of chemoradiotherapy, just before surgery. Tumor response was evaluated according to the RECIST criteria, and toxicity was assessed by CTCI and RTOG criteria. In terms of clinical response comparison, although there is no statistically significant difference was found between the two arms, but numerically IMRT shows better response than the 3D-CRT. In terms of toxicity comparison, all sorts of toxicity, hematological, gastrointestinal, and other non-GI toxicities, IMRT shows less toxicity than the 3D-CRT arm. Especially diarrhea and radiation proctitis shows significantly reduced toxicity in IMRT arm than the 3D-CRT arm. In terms of compliance, patients treated with IMRT shows better compliance than the 3D-CRT arm, because patients treated with 3D-CRT shows more treatment break, longer treatment duration, and more mean radiation dose. So from these results, we see that IMRT significantly reduced grade 2 or more diarrhea and radiation proctitis compared to 3D-CRT, improving treatment tolerability and compliance. This aligns with the findings by Samuelian and his colleagues' research conducted in 2012, Parekh and his colleagues' research conducted in 2013 in USA, and we and his colleagues' research on 2018. IMRT showed slight numerical advantages in complete clinical response and tumor downsizing, and the result was similar from Huang and his colleagues' research done in Taiwan in 2016, and Bai and his colleagues' research in 2017. Although the 3D-CRT group had higher rates of grade 2 or more anemia, leukopenia, and neutropenia, but these differences were not statistically significant. IMRT improved treatment completion rate, reduced toxicity, shortened treatment duration, and lowered dose, enhancing compliance and tolerance, as shown in the research done by Samuelian, Parekh, Wei, and their colleagues. Now the concluding message. These studies showed no significant difference in clinical response between the two arms. However, IMRT had a better toxicity profile with significantly fewer cases of diarrhea and radiation proctitis, and a shorter treatment duration that improves patients' compliance. But despite these benefits, 3D-CRT still remains a viable option in low resource settings like our country if we combat the toxicities. Thank you all. Thank you for the patient sharing.